Good evening, everyone. Dr. Mora. I'd like to welcome you all to this CME. And today's speakers are Dr. Onyango, and we have Dr. Kareko as the moderator. I'd like to welcome Dr. Kareko to please introduce herself and subsequently introduce today's speaker. Thank you. Welcome.
Okay, thank you. Thank you, Mora. Good evening, all. Today, I would like to, I'm Dr. Kareko. I'm a VR surgeon currently working at CTI Hospital, and I have the pleasure of moderating today's talk. And our presenter for the day is Dr. Oscar Onyango, who's a consultant ophthalmologist and VR surgeon currently working at KNH. He's also the head of department at Nairobi Hospital, the ophthalmology department at Nairobi Hospital, and is also the proprietor of Nairobi Eye Associates. He's currently part of the Elevatum study in Kenya, and he also has a penchant for retinal dystrophies and has done a study on inherited retinal dystrophies in Kenya. So today he'll be giving a talk on retinal vein occlusion, a paradigm shift in the management. So karibu sana daktari, the floor is yours.
Thanks, Catherine. Thanks for this opportunity to talk to colleagues. I can see we are 46 now. Okay, really good. So we're discussing retinal vein occlusion. My role today is actually not to say so much new stuff. Most of the stuff is already known, but just to bring in a new angle. That's why I call it a 4-on-1. We are blocking a new treatment paradigm for RVO. So that's for retinal vein occlusion. We can just proceed. Let's see. My slides are stuck. My slides are not moving. Evans?
Can you just stop doc and reshare? I think maybe it's
share.
Yeah.
Share screen. I go back to that again.
Then put on presentation mode.
The slideshow, you mean?
Yes.
That one? Okay. Yeah, that's good. It's financial disclosures there. So this is the image we're talking about. This is an example of a sentinel retinal vein occlusion, yeah? And you can see the hemorrhages, all 4 quadrants. You can see areas of nerve fiber layer infarcts, what you call cotton wool spots. You can tell definitely there's a big problem in this case. This is something you see every week. Whether you're a retina person or not, these are things you'll definitely meet before you send to us. So it's good to know what exactly is going on globally and even locally with this kind of thing. So just going straight to the point, RVO carries a high treatment burden. Intravitreal anti-VEGF therapy has been picked as the first line of treatment for macular edema due to RVO. Such a statement is a very heavy statement. This comes from very many studies, using laser in the CIVO study, central vein occlusion study, using steroids, dexamethasone or triamcinolone, that was a SCORE study, using ranibizumab, which came up as pretty promising in the CRUISE study, and aflibercept in the Copernicus and Galileo studies. Even there are surgical elements that have been put into CRVO, for example. But all in all, intravitreal anti-VEGF is the gold standard, saves you a lot of trouble, etc. And patients desire fewer injections. That's a fact. We all know how patients get anxious when we take them for the injections and all. And everybody wants few appointments. You want to do your own things out there. You want to go to the shamba. You want to do your own businesses, etc. So regular appointments is a problem. Frequent injections are a problem. And healthcare resource utilization. You have to prepare the theater. You need that equipment. You need those swabs. Everything has to be ready. You need the nurse to assist you in whatever you're doing. So all this creates the high treatment burden for treating RVO. Straight on to faricimab, the new baby in the market, bispecific antibody. Okay, it's 1 molecule, 2 disease pathway targets. And on the left there, it is known that angiopoietin-2 vitreous concentrations are elevated of all retinal diseases in RVO. You can see the pattern we have here. Diabetic retinopathy also comes close, and PDR is hanging somewhere there. And dual inhibition of Ang2 and VEGF-A with faricimab should stabilize vessels and reduce neovascularization, leading to durable efficacy. I'll show you a video shortly. I beg your pardon, incidentally. The guys who came to, I think it was Coexa Mombasa, If you don't like cartoons, you can just pause a bit now, but the rest who did not enjoy this ties home exactly what faricimab is doing. So here we go. Sorry. Okay, ladies and gentlemen, after watching that cartoon, really a lot of this will become clearly more evident. In this next slide, basically, I'm just trying to highlight what the video is talking about. Under physiological conditions, basic homeostasis, no acid-base problems, no leakages, etc., we have angiopoietin-1, which is a normal factor that is produced from pericytes and platelets. And it activates tyrosine kinase 2 receptor, and it blocks the VEGF receptor 2. So any VEGF-A circulating doesn't have its effect, but tyrosine kinase 2 acts, okay? What does tyrosine kinase 2 do? It tightens endothelial cell junctions, so you end up with less leakage of fluid material at endothelial, at capillary level exactly. And you also end up with more migration of pericytes, which wrap themselves around the endothelial cells and support the endothelial cells, reducing chance of leakages of vascular components. And you also have a better vascular stability and homeostasis. So you see, this is the normal state of affairs which you'd expect to have. But what do we normally have? You have acid-base imbalance, hyperglycemia, the ischemic processes, etc. So you end up with less angiopoietin-1 and angiopoietin-2 gets upregulated. What does it do? It stimulates VEGF receptor 2, so all the VEGF effects start checking in, and it blocks the effects of tyrosine kinase 2. So end up with endothelial tight junction weakening, vascular leakage, increased inflammatory processes, pericyte dropout, less support for the endothelial cells. Okay, more and more leakage is happening, and that's what gives us the edema as we see. Furthermore, the VEGF effect, vascular sprouting and neovascularization occur. And ultimately, that gives you the neovascular status that we see in diabetic retinopathy, for example, or in CRVO and BRVO components, okay? So what we do know is real world, there's a lot of focus of real world. They mentioned real world trials, yeah? Clinical trials like what we're doing now, Dr. Kareko mentioned at the beginning, the Levetam trial, we calculate for you everything. Your visits are calculated, the OCTs are calculated. Everything you do is timed to the T. Now, real-world studies mean you're coming from home, the normal KNH patient, CTI, etc., and you will not visit hospitals with a fixed timetable the way we do it in clinical trials. So that translates to fewer injections, both on the side of BRVO and CRVO. It translates to fewer injections when you look at the clinical trials on the left here, the blue, from baseline to month 12. If you compare that with real-world studies, definitely have much fewer injections, 4.9 compared to 9. If you look at long-term extension trials, this one you're looking at from month 12 in the second year of study. the lowest level, fewer observation, fewer monitoring, much fewer monitoring events. On CRVO side, similarly, you have the same thing going on. And you notice it's very easy to count the number of injections in clinical trials. But when you come down here, patients are busy doing other things. The monitoring is not as easy, and you end up with fewer injections. And what does fewer injections translate to, ladies and gentlemen? You end up with fewer vision gains, and you end up with less letter. Okay, so if you compare clinical trials, 18 letter gain from baseline up to month 12. Real-world studies is 13 letters. Incidentally, we tend to use the ETDRS chart for clinical trials, better, easy. It's easier to, more reproducible than the Snellens. Though Snellens also has come in vogue because of that's what we do, that's what we refract with. That's the normal 612, 66 kind of vision. But when you count letters, it's more objective, and someone understands exactly what you're talking about. So if you look at the letter gains in long-term extension trials for BRVO, it actually goes below 0. So you end up losing the vision gains you had in the first year. CRVO is very similar, more or less the same kind of effect you see. Real-world studies, much, much fewer. Real-world studies is where we are most of the time. Long-term extension happens, like when you do clinical trials on the second phase. So I already mentioned this before. So what was Balaton and Comino? These are randomized, double-masked, active comparator control trials, phase 3. When I talk of active comparator, basically we mean you're comparing molecules that are already active, they're already working. So for example, you're comparing aflibercept and faricimab. You can compare different kind of molecules. It can be in any other ophthalmology, cardiology, etc. So you're comparing things that are already working, but you're looking at efficacy, probably is not in doubt, but durability. How many visits, how many injections, how does the molecule work? Remember here we are targeting 2 pathways with faricimab, as opposed to the other pathway that just targets the VEGF. Again, Comino, 729 patients, 553 for Balaton. Africa missed out on this one, but Roche has changed this, and we're more and more being counted on the global scene. And eligibility for the study, general, of course, must be over 18. Inclusion criteria, RVO less than 4 months, diagnosed less than 4 months prior to the screening. Of course, if it goes more than 4 months, you know the sequelae that would come with that, the ischemic processes, neovascularization, etc. The BCVA, less than 73 letters, going up to 19 letters. That's what's counted at 4 meters, or the Snellen equivalent is indicated there. Central subfield thickness, more than 325 microns. And the key occlusion, the key ocular exclusion criteria, was any cause of visual loss, even if there's RVO. For example, you have RVO, probably it's more than 4 months since you're diagnosed, and you have neovascular complications, you have membranes, etc. That one is an exclusion criteria because you're not going to inject anti-VEGF in a case like that. You end up with more obstructional problems, etc. You treat the complications that come with the glaucomas, etc. And any prior treatment for macular edema, be it steroids, etc., or PRP, or any other anti-VEGF incidentally given already, macular laser, any cataract surgery, the inflammatory processes that come with surgical procedures. So you have to give it at least 3 months. Even for elevatum, it was similar to this. At least 3 months after the surgery, then we can enroll you. So phase 3 study design, those are the numbers there, population I've mentioned. Primary endpoint, change from baseline, change of best corrected vision from baseline at week 24. So you're counting from day 1 to week 24, which is 6 months. And there were 2 arms in both of the studies. One arm had faricimab, which is a 6 milligram dose, given monthly up to week 20. So those are 6 injections. The other arm had aflibercept, which was given monthly up to week 24 again. So you see there are 6 injections. Now, at week 24, that was called the primary endpoint. So what happens at week 24? Both arm A and arm B were switched to faricimab in a form of a modified treat and extend regime, which I'll allude to shortly just now, because this modified treat and extend, which can also be called the personalized treatment interval, has revolutionized like anti-VEGFs globally, because now you're not fixed in terms of how you treat after loading. Depends on how much vision you have, how much vision you've gained, and how much OCT changes you have. Are you clearing edema or you're not clearing? Okay, so basically that. And then so you have faricimab, you have the sham injections. Remember, even when you're receiving a sham injection, you're still doing the visits. Remember, clinical trials are fixed, okay? And if you're talking about double-blinded, you're talking about, even the investigator doesn't know exactly what he's giving, yeah? So it's every month, every month, every month, and each time it's an OCT, fluorescent angiography, etc., etc. quite a process. Okay, so the second primary, the primary endpoint that was at week 24. There's that assessment I'll talk about shortly, the treat and extend. Then all this was followed up to study end at week 72. Now, RVO modified treat and extend regime. Just to make it simple, this looks a chart, many fancy colors there. What you're looking at from baseline is you must have achieved edema resolution up to 325 microns, which was the inclusion criteria, if you recall that one. Secondly, you must be achieving letter gains. So if from baseline, I'm looking at your change in CST compared to the reference CST, okay? We look at how much central subfield thickness you've achieved, less edema up to what level, how many microns, and then you're looking at vision, how many letter gain do you have? Every 4 weeks. Now, this you don't have to calculate sitting down with a piece of paper, etc. There's an algorithm that does for you this. And this is being used globally already. This has proved to be like a game changer in treatment of macular edema, the anti-VEGFs, angiopoietin, etc. And what was found was with faricimab, it's you extend every 4 weeks or so because you get increased letter gain, you get resolution in edema. Okay, I'll show you some results shortly just now. So basically, that's a modified treat and extend regimen. I just I simplified it some so I don't get worried too much about the green and the reds and what. But you must have achieved 325 microns on the OCT before you start being extended. Okay, there are always subsets of populations that when you do clinical trials where you'll inject every month, etc., they'll never achieve that standard. They'll stay up there. They'll stay at 4 weeks for the whole time of the clinical trial. So you can imagine if it's up to 1 year, those are 12 injections, the treatment burden that comes with that, etc., etc. But that's on the clinical trial side. It's easy to do. Real world that cannot just exactly happen. So study efficacy endpoints, BCVA change from baseline at week 24. Secondary efficacy objectives for part 1 up to week 24, the BCVA change, and are you gaining or losing? You can actually also lose letters for various reasons, incidentally, ischemic processes, etc., the macula, or CST change from baseline. Then we also have the questionnaire, which is common in most clinical trials. Visual function questionnaire asks about your general well-being, the day-to-day activities, are you able to work, use computer, drive, etc., etc. And you do this regularly over time, as we do for the Elevatum trial also. And the second part, from week 24 to week 72, similarly, now looking at proportion of patients who are on Q4 weekly means every 4 weeks injecting, every 8 weeks injecting, every 12 weeks. So the patients who, for example, have done so well, by the time you're on Q16 dosing, it means they injected once in 4 months. I mean, what beats that? You know, that's where you'd want to be. So you come to the hospital for visits 3 times in a year, literally. That would be a real world kind of game changer. Same endpoints in terms of vision and OCT. So what I found, remember, we're talking about active comparator control trials. So efficacy is not in doubt. So you can see the letters. Aflibercept gives you 17.5 letters by week 24. So there is a gain, and 16.9 letters on the faricimab arm. But non-inferiority, basically you're referring to very minimal changes between the two. That's on the Balaton side. On the Comino side, similar again, 17.3 letters and 16.9 letters. Yeah, pretty similar kind of thing. If you look at the OCT findings across both studies, again, when starting at baseline, coming all the way to week 24, if you look at the reduction in the edema, 304, 311, as opposed to in the Comino, 448, 461. Pretty similar, okay? Now, adding a new paradigm, as we're talking about different paradigms that are being used, macular leakage has been found to be a good biomarker for letter gains when you're dealing with macular edema. Why is this so? There was a study, I think that was the Ruby trial that looked at aflibercept role in DME, and it was actually found, yes, that was Ruby trial. Aflibercept compared to those an anti-angiopoietin 2, nesvasumab, something called nesvasumab, and these two are being compared efficacy-wise. And what was found was during the fluorescent angiography phase, it was found that as you keep injecting both of these medications, macular leakage was resolving. You're looking at FLA, yeah? So you inject a dye in the peripheral vein, you wait for the late phase 6 minutes and above, and you measure how much macular leakage you have on the posterior pole in millimeters squared. So over time with the injections, it was found that the less macular leakage you had, the better the letter gain. But at the same time, more or less, it was almost like 1 millimeter squared reduction in macular leakage translated to 1 letter gain on the ETDRS chart. But an interesting thing that came out of the Ruby trial also was when you separate, you have aflibercept and esfazumab, which is it's directly a clinical anti-angiopoietin 2. When you give these two separately, there's no benefit. You'd rather just give us aflibercept alone. This was the Ruby trial. Yet, when we have our bispecific molecule, faricimab, it's two molecules in one. I mean, the best way of looking at that, as I was thinking, is when you have a plate of ugali and osuga. If you take ugali and chew it separately and swallow it, then you take the osuga, chew it separately and swallow it. It's not as beneficial as having the ugali and the osuga put in the mouth together and swallowed. If you don't understand that, I don't know which other example I would give. Similarly, there was a panorama study that looked at severe NPDR with aflibercept, and it also came up with the macular leakage theory. So in clinical practice, it's not routine. This is easier for clinical trials. Doing fluorescent angiography in patients regularly, there are all risks we know that come with that. But it's good to know that actually macular leakage on fluorescent angiography can be used as a biomarker to see how much letter gain you're having. Okay, so change in BCVA, this is just a summary. We're looking more of the extension phase here. Remember, everybody was extended on faricimab, even if you started on one arm was faricimab, the other arm was on aflibercept. Mean number of injections were more or less similar, 4.8. Letter gain, as you can see, is indicated there for both the Balaton and the Comino, the CRVO studies. Again, the two, when you look at the graphs for BCVA and the graph for OCT, they all, it's like there's a mirror in between them. Yeah, non-inferiority in terms of letter gain, but in terms of injections, you always end up with slightly less injections on the faricimab side. Okay. And this, just to summarize the many pie charts here, but if you look at on the Balaton side, the faricimab Q4 being given every 4 weeks, then switch to faricimab on the treat and extend as opposed to aflibercept Q4, then switch to faricimab. 64% of patients managed to be moved to being injected every 3 months or every 4 months. Okay, on the aflibercept, it was 57. All right, remember, started off with aflibercept and switched to faricimab. On the Comino side, more or less, there's more ischemic process going on here. 3 monthly, 4 monthly, 45%. Here, aflibercept had the day, somewhat, yeah. Q12, every 3 months and 4 months, slightly more on the side that was loaded with aflibercept. So what's the take home for this? BCVA gains from the Comino and Balaton studies confirmed by week 24. You had good BCVA gains, which were maintained all the way to week 72, similarly with CST reduction on OCT. More than 45% of patients on the Q12 faricimab dosing, more than 45% of patients on Q12 or more, okay, up to Q16 by week 68. And faricimab was well tolerated with a good safety profile. It was approved by the FDA for treatment of RVO. Just a quick chart here. I know for us as ophthalmologists, okay, endophthalmitis is the first thing I can imagine Catherine and any other retina person in this crowd will be looking at. Let's see what the endophthalmitis looks like. You can see just had one in the Comino, the one that was loaded with aflibercept, no endophthalmitis. Inflammatory processes were hardly, okay? In the Comino, there's more ischemic process going on, so more of inflammation, both sides, I must say. But for us, in clinical trials, ocular, any adverse event, a patient talking about an itch, talking about foreign body sensation, talking about maybe tearing, talking about anything out of the ordinary. We have ocular adverse events and non-ocular. Even talking about back pain or foot pain. I always like giving the example of, you remember the blue pill, what's this thing called? Viagra. Viagra is being used for heart conditions, but it was found that it was also sorting out problems of erectile dysfunction in the men. And that switched the whole shift into looking at other kinds of medication that would work in a similar way like that. So it's always good to know adverse events, are they good or bad? There are those that can be healthy, there are those that can be bad. Majority of times, of course, they're looking for things that are bad to the patient. Ocular adverse events of special interest, I must mention this, is any ocular adverse event that has a risk of visual loss if not treated either medically or surgically. And those are the ones to look at here. So not necessarily endophthalmitis, you can have other things happening. So 2, 1, you had 12 in this lot here and 8 in this lot here. Basically, this table tells you things are pretty safe. Yeah. Oh, sorry, here the serious non-ocular adverse events somewhere down here. Yeah. More or less, both, I must say, both arms are pretty safe. Nothing, no cases worth calling out for. This is the second phase now, part 2, from week 24 to week 72. And similarly, anything non-specific, as we've seen in our trial also, I mean, it's reported and documented. Because you might find maybe your medication causes eye redness, like some of the glaucoma medications, and it's found to be just hyperemia, nothing, it's not a disease process, but it is good to document it, so it is known. So that's why you see these numbers are pretty high in terms of any ocular adverse event. Okay, coming down again, endophthalmitis, I know, again, 1, okay? The rest are more or less similar across board. So, looking at, I think this is just summing up again what I'd started off saying. Clinical trials give you that, it's an artificial environment, ladies and gentlemen, but it gives you the maximum benefit, like what we've seen in our study going on and what we see other places also. Real world studies give you less, but definitely you're treating something and you're getting later gains. Long-term extension studies, that's in the second year, give you the least, okay? And similarly, if you're looking at mean change in ETDRS letters, same story. Less injections translates to less gain in vision, and at times loss of visual gain that you had achieved in the first year coming into the second year, as you can see in long-term extension studies over here. And similarly, that was on the BRVO side. This is on the CRVO side, more or less mirrored, same. Most studies on the CRVO side there, but more or less same kind of study results in fact, for the CRVO long-term extension study, sometimes you lose so many. You can imagine losing up to 7 letters, which if you had gained probably 7 in real world, then you lose another 7, you're back to square one where you started off. So need for durability. Incidentally, efficacy for most anti-VEGF is not in doubt. Durability is in terms of now targeting 2 pathways, and they're giving fewer injections, fewer hospital visits, less strain on resources, and that's what everybody wants. In terms of conclusion, randomized clinical trials, you have monthly monitoring, as we've seen, frequent injections. Patients with macular edema benefit, okay? They experience better BCVA gains and resolution of the edema. Real-world studies, there's less frequent monitoring. The patients with the edema due to either of those conditions receive fewer injections and do not achieve as good BCVA gains as compared to the control trials, RCTs. Long-term extension, there's less frequent monitoring, fewer injections, patients are all over doing other things. Patients with macular edema do not achieve much, they even lose in some instances. Okay, so you need more durable therapies, which is offered by faricimab. Now, just an example, I'm giving a small case as I finish this, I'm almost done. Real world, real difference. So I present a case, a lady presented to us, this was January 2022, 52-year-old female, hypertensive on regular medication. She was referred as a case of CRVO already confirmed and had been done retinal laser. Those are the vision was 636. And pressures were within normal limits, early cataract, okay, panretinal laser, scars, dull fovea reflex, right eye was normal. So all the pathology was on the left side. That's OCT, you can see the left, okay. You can see intraretinal fluid pockets there. You can see the edema, which is slightly off center, by the way. You know, it's more on the temporal side as opposed to the nasal side, but there is edema and it's affecting the outer retinal layer. So photoreceptors, external limiting membrane over here, there's an issue. And so that was what we started off with, 367. If this was a clinical trial, well, she would have enrolled for this, for any of the communal things and stuff. So we started on intravitreal aflibercept, that was 2022. She got 3 doses, efficacy is not in doubt, got lost after the 3rd jab. Resurfaced a year later. Remember that was early 2022, came back June 2023, complaints of visual drop over a couple of months. Remember, these are a couple of months, not a week, not 2 weeks, couple of months. She stopped her follow-ups after receiving anti-VEGF because her vision had improved after the 3rd dose of aflibercept and didn't see the need for a review. She continued doing whatever she does. So this is where we are now, ladies and gentlemen. This is January 2022. This is 30th June 2023. You even have a cyst, big cyst there. We're at 480 or thereabout in terms of micrometer thickness, CST. And again, temporarily, you notice intraretinal fluid, disruption of outer retina. Okay. So what did we do? Started on faricimab, gave 6 monthly, okay? 6 milligrams every month, 3 doses. And we end up with a pretty good macular contour. We're at 245. We started off at 480 or 490. Yeah. This haze here now became due to cataract. Okay. She got lost at her 3rd dose, September. She resurfaced in December. She reported visual improvement, but gradual loss now. She came earlier, okay, over 4 weeks. Eye exam, she has a PSC and was due for phaco, I believe. Probably Nyamori must have seen this lady by now. Of course, follow-ups will go on. Remember, she had laser. Remember, I mentioned at the beginning, anti-VEGF is a good line. We don't do laser as first line anymore. The tissue destruction has not been shown to have any benefit. The only time laser has benefit is when you have neovascular complications. Okay, that's when you can have your panretinal lasers. But I think with those few remarks, I'm done. Thank you, everyone, for your audience.
Thank you, Dr. Onyango, for that insightful talk. Indeed, it's a good thing to have a new agent in our arsenal for treatment of macular edema as a secondary either to RVOs or DME.
Yep.
I would request the audience to kindly post any questions that they may have on the chat box. Then Dr. Onyango can respond to them. So definitely satisfactory treatment for macular edema is getting an agent where you will have, fewer injections and then definitely increased visual gain. So until we get to that point, I guess we'll keep on doing more studies, but faricimab is definitely a very promising agent.
Yeah, very.
The new kid on the block.
Very good response, of course, within elevator also. We can't talk about that one yet, but
yes,
a good response also in like real world. We have patients outside the clinical trial. I think now I've done what, 4 or 5 patients who are doing pretty well on it. So yeah, okay. It's there for use. Anybody can access it.
Can I ask how much it is to the patient? Because I'm sure most people will be.
Is Catherine in this call?
Are we allowed to ask?
Catherine Mwangi Roche.
Maybe she has to be unmuted.
Yeah, hello, good evening, ladies and gentlemen. Dr. Oscar, thank you for the wonderful presentation. I was waiting for the rights to be able to speak by the host, so thank you so much also. So you're asking about the cost for faricimab. And so first of all, I'd just like to clarify on the question of this price, but first of all, to clarify that it has not yet been registered. We are still waiting for PPB's authorization, and we're hoping to get that hopefully before the end of this year. So the price is also concomitant to that, to the present situation of pre-registration, because there's a certain price that we cannot give up until it is registered. So the current price at the distributor and 3 distributors, we have Sagifam, Laborex, and Harley's. It's retailing at 62,000. However, by the time it gets to you, of course, there are some certain markups. So they have now also extended this to around 72,000. Yeah. So that's the current price, Dr. Oscar.
Thanks, Catherine.
Thank you.
And Catherine, again, your question is answered. So both Catherines have answered each other. Can I stop sharing?
Okay, fine. I don't know, Dr. Was the video, did it have any sound? Because I've just seen a comment from one of us.
Yeah, my side had sound. You didn't have sound on your side?
Yes.
Oh, there was no sound?
There was no sound.
Oh, strange.
Okay, maybe as you look for a way to do that, we can move on to some other questions.
I can stop sharing maybe.
Okay.
Share again. Let me see. Let's come back to it. Let's come back. It was quiet at the beginning. I was opening it up again, but it didn't. I think it was after this. Just before this. Okay. Can you hear them? Is there sound?
Still no sound.
Oh, then that one is beyond me now, man.
Okay. No problem. Or maybe Evans, can you step in?
No,
low resource may affect your audio quality. Try some, because I can hear it very well on my side. So you guys are just seeing a silent movie.
Yes, it's just the animation, no sound.
Maybe there's a way we can share it even on the WhatsApp side, maybe.
Okay.
Yeah.
So we have a question from Dr. Jaffaji. He actually has, so he says, thank you for your wonderful presentation. Considering the effect lasts for 3 months, easy with faricimab, why inject monthly? Why do the monthly injection if at all the effect has been shown to last for 3 months?
Okay, what I'd say to that is you have to achieve a certain biological level at capillary level. You have to achieve, what's the word? I'm trying to look, pharmacokinetics, pharmacodynamics. There's a level you must reach before you start extending. It's been tried, you can start off even if it's one dose every 3 months, 4 months, but you need to achieve a certain effect so that you've already worked on the tight junctions to a certain degree. You've already worked on pericyte migrations and stuff, so that the effect that you'll get within the extension period already has something to back it up. Maybe that's the best way I can put it. Yeah, but it has been discussed. Why not just start? In fact, the discussion of having a molecule that can be done once in 6 months, once in 8 months. But what has been seen is loading is pretty important in terms of achieving that effect at capillary level before you can extend the benefit of extension.
Thank you. Thank you for that. He also has another question. If it has equal efficacy to aflibercept, then why use the new kid on the block?
It's all the same efficacy. It's all the same. The indications are different. I mean, as we normally say, we give patients all the options. I diagnosed with CRVO. Oh, incidentally, I forgot to mention, you must have systemic assessment. All CRVO, BRVO cases, even in the Kenyatta, when we have a registrar, a cardiovascular assessment is very critical. Don't just focus on the eye. So someone comes, you've diagnosed a CRVO, BRVO thing, the cardiologist, all the carotid, the assessments, echoes, and all those things must be done. The physicians have to be happy, cholesterol and such. So that's on the side. But what we see is, if I offer you all this, we've started off with whatever vision, I tell you this is there, this is there, this is there. And this one, we've done research to find that we can actually extend it. Once I've given you, be it 3 or 4 or 5, 6 injection, whatever, incidentally, I can go up to 4, even loading, and extend from there. But remember, I mentioned the modified treat and extend, the personalized treatment interval, as it's called. You can also have your own algorithm that you use, which is known to work with faricimab more than the other molecules. But it can be tried other molecules and you see how they work. Remember, they only work on VEGF. They don't work on the other part, the angiopoietin pathway. So my take home for Shafiq's question is, give patients all the options. And secondly, you're looking at attacking different pathways with one molecule, as opposed to you having a single molecule that targets only one pathway. Yeah.
Okay. Thank you for that. Dr. Victor commends you for the good presentation. I think your question about the cost has been answered. Dr. Njoya is asking, how does it compare with brolucimab in efficacy?
I don't know. I've not compared. I've not used brolucizumab. We'll know in due course, but I've not injected a single brolucizumab, so I can't compare on that. Yeah. Incidentally, I've also not seen any studies comparing. You remember the active comparator, when it is known that the two are similar in terms of efficacy, but durability is what changes them. I've not seen any study on brolucizumab comparing it to faricimab. I know brolucizumab comparing to aflibercept has been there, but this one I don't know. So we wait and see if we'll be approached or not.
Okay, thank you. So Dr. Ogundo is asking, I guess maybe this is to Catherine. The 72,000 shillings, is that for one injection, or can you split one dose for multiple, like, the way we do Avastin and Eylea? So is it just for one dose?
Let me answer that for Catherine, because I'm the one in the procedure room. One dose. And actually, there's a markup. Whenever we buy it, it's in the 80s. Just to tell you, it's not in the, it's in the 80s whenever we get it. And as opposed to, I think it was aflibercept, when they started, it used to be almost 1.5 mils, and you'd split it within 3 patients if you're using the syringe that has the needle attached to it. But this one, it's one dose, 0.05 mils. Once you've done your dead space thing, it's 0.05 mils, and that's all. So it's one dose. That is medication. You've not counted the surgeon, you've not counted the theater fee. Yeah.
It could easily hit over maybe 120.
It depends. Maybe you inject, if the surgeon is injecting for free, I mean, feeling thoroughly philanthropic, you know, so. I don't know.
Okay. So another question from Dr. Ogundo, would you recommend that as long as we can follow up with an OCT, any ophthalmologist can give the anti-VEGF, or is it a preserve of the VRs?
VRSK, Catherine, I think you're one of our officials. The training is such that any ophthalmologist can give an anti-VEGF. You know the anatomy of the eye, you know. Actually, right now, we've been giving anti-VEGFs in preterm babies, you know, for ROP, and we train our registrars to do that. So it's I believe any eye care worker, I'm taking a bite on this. I know we have nurses, ophthalmic nurses, I think somewhere, is it in Europe somewhere, who are giving anti-VEGFs. I believe even in our setup here, we have clinical officers who give anti-VEGFs outside Nairobi. We know that, I mean, Avastins and all. As long as you understand the anatomy and you have a backup in terms of, in case of any problems coming up, you have questions to ask. Dr. Ogundo, feel free. You can always consult if you need anything, but I mean, you diagnose and you can see this is macular edema due to CRVO, BRVO. You don't need, well, I don't mind the referral, but you can proceed and treat. As long as they're doing the close follow-ups, you know the cardiovascular workup is going on, you know the OCT changes that you know there's a problem. If you continue injecting, for example, vision is not changing, you're looking at probably doing an OCTA to look at the foveolar vascular zone, or even doing a fluorescent angiography where it is done, where it is referred to. So there are certain things as a retinal person we think more than now just general ophthalmology, but starting off doesn't harm. I mean, maybe the patient is traveling and something has you have the medication with you, give by all means. And continue, you load whichever it is you're loading, and subsequent to that, you can send to any of us to have a review. I'll send, and if you're sending it to me, I'll say just for a review. I will not hog your patient. I'll have a look and send back to you, continue, you know. Yeah, so I hope that answers that, yeah.
Yeah, to chime in, I think if we were to leave it as a preserve of the VR surgeons, then almost 3/4 of our population will go blind. Like coast, there's no VR surgeon there.
Yeah.
You know, Northeastern. So I think as long as you know what you're doing, and once you hit a roadblock, you can refer appropriately, then I think, you know, a general ophthalmologist should be able to offer care.
Yeah.
So a question from Dr. Jaffaji, how do you explain the higher adverse event rates in BRVO vis-a-vis CRVO in the studies?
Adverse, the ocular, just general ocular was the highest. You see, based on our study experience now, Shafiq, any discomfort a patient has is an adverse event. Even if someone reports the grittiness, anything, you see, that's why they're classified as serious ocular adverse events, serious ocular adverse events of special interest, and just simply ocular adverse events. So they're different. And the one that had the highest numbers was just the general, if you can call it general ocular adverse events. And those are the most non-specific. Sometimes we observe, you're looking for inflammatory processes, looking for superficial punctate keratitis, you're looking for papillary reactions in the conjunctiva. You look for all that and there's nothing, and you end up giving the patient a lubricant and they get sorted out, you know, as simple as that. So anything reported, you will definitely have a high report of ocular adverse events in any clinical trial, because when you're taking consent at the beginning, and this consent are very, very many pages, you tell the patient anything odd you feel, anything out of the ordinary, report it. Anything. Even if you feel like an eyelash and not an eyelash, you tell us, you know, anything, so that we examine and see, is it something worth reporting or not? And there's a reporting platform for all these adverse events. That's why you're seeing there are many like that. But of note, look at the ocular adverse events of serious interest. That's where the clincher comes in, leave alone even the endophthalmitis and all that. These are adverse events that have a potential for causing blindness if you do not intervene. Yeah.
Okay, thank you for that. Last question is from an anonymous attendee. So he says, great presentation, Doc. When the letter gain isn't in proportion to the macular CST, what next? And the ocular media is clear.
Yeah, that's an interesting one. That's when you start talking about ischemic. So you're having resolution of the edema, for example, but the letters are staying the same, or sometimes even worsening. That's when I was talking regarding Cynthia's question. Now you have to look for signs of ischemic processes going on outside what you're giving. And remember, anti-VEGF given permanently also gives ischemic process. I mean, you're suppressing neovascular factors, for example. So that's when you start looking for example, if you have access to a CTA, the intermediate capillary plexus, which is a component of the deep capillary complex, would guide you in terms of knowing, is it wide? And you have to know the normal from the abnormal. Yeah, OCTA is still evolving, so you have to know the normal from abnormal. That's one non-invasive thing you can do. But the other thing would just be a fluorescent angiography and see, when you compare the two eyes and things, compare, see, is there a wider foveolar vascular zone or not? That's where I would put it. But this question can be answered by you, Kareko, Shafiq, any of the other guys, retina guys. What else would you do? Because you just can't keep injecting, and you have resolution of edema. The letters have not changed, and we have clear ocular media. The questioner is saying, what more?
Maybe you could consider micropulse laser.
Option one. Remember, there's no edema. It's it's clear that the letters are the ones that are not increasing, but your macular contour is fine. What do you do?
Counsel the patient about the underlying ischemia.
Yeah, that's the only thing.
You can't keep flogging a dead horse,
Yeah, very true. Very true. Shafiq? Shafiq is on?
Maybe he needs rights to comment. Maybe he needs to be unmuted. Okay. I guess maybe he's not on the call.
Thank you very much.
Hi, Shafiq.
Hi, how are you, Daktari? Thank you, wonderful presentation.
Asante. Give your comment on that query.
Yes. Actually, if you find that there is ischemia, that marks the end point of your treatment on its own.
Yeah.
That on its own just marks an end point. You're not going to achieve anything else much. So you just stop there.
Yeah,
that's it.
Exactly what we're saying, basically. You confirm it and you leave it. Counsel the patient, as Catherine has said, and leave it there.
Okay, thank you so much, Dr. Oscar, for availing yourself and for the wonderful presentation. Thank you all attendees for the engagement. Now I'll hand over the meeting back to Dr. Mora.
Thank you, everyone. Thank you, Dr. Onyango. Thank you, Dr. Kareko. And for the attendees, for the questions, I'd like to welcome Roche. Roche is the sponsor for today's meeting. And I'd welcome Dr. Angela Kiraba and Catherine Mwangi. Whoever is presenting, please, you can project your presentation just for a short while.
Thank you so much, Dr. Mora, and for the fraternity. It's a pleasure to be here with you today and to be your sponsors for this session. I'd like to invite Dr. Angela Kiraba. She is a country medical director at Roche at East Africa, and we work together hand in hand to build up the ophthalmology strategy for East Africa. So most welcome, Dr. Kiraba, to share your screen and your slides.
May Angela be having the video that couldn't play on my end? Maybe she would play it. It's not long. It's like 2 minutes or something.
Actually, that's right. We could look at whether she has it. But Dr. Mora, have you managed to unmute her and give her the rights for presentation?
Hello.
I believe
Evan, you can hear me now.
Yes, you're on.
Yes,
thank you so much.
Thank you so much. Yeah, thanks for giving me the rights. Yeah, and thank you, Catherine, for the introduction, and Dr. Oscar and Dr. Kareko for the presentation. Yes, as Catherine mentioned, I'm the country medical director based here in Nairobi for the Roche East African affiliate, and I'm really glad to be here to be able to get a chance to speak to you all. I'm trying to see if I can actually get the presentation up, but in the meantime, I'll just speak through some of the things that I had wanted to share with you. And this was just about our Roche journey in ophthalmology. We just wanted to let you know where we are at right now in ophthalmology and where we've come from and what exactly we hope to do within the ophthalmology space. So I think what is of interest for us in ophthalmology and in Roche specifically is that we really wanted to follow innovation and excellence. And you'll probably see from the 2 slides, I only had 2 slides to share, the pathways that we have taken to look at the more innovative solutions towards the problems that these patients actually suffer from. And our idea there is to address the unmet medical need and transform the treatment landscape for a variety of eye conditions, including retinal vein occlusion, which is something that we just talked about today. I'm going to, just let me know if you can see my slides. Give me a second, please. No, I don't think I actually have the ability on my side. Catherine, do you have some ability on your side to share your screen? Otherwise,
No,
if not, I'll just speak through.
Neither do I, but
think
let's
I've given you the right to share, because who can share, host and panelist?
I only have the mute button that is open. But if not, so that we also don't
No,
keep,
just try. Just try.
Okay. I only seem to have the chat to the show captions buttons at the bottom and then the mute button.
That
same
sounds
here.
Yeah.
that sounds funny, because the same I've allowed sharing for everyone, including Dr.
Okay.
Oscar.
All right, but I mean, it's still fine. I can speak through what I wanted to just speak
Oh,
through.
I've seen where it is. Oh, no,
have you?
but it's
Catherine,
not.
can you share?
No.
Because if you,
it's
okay.
enable sharing side-by-side mode. I don't know. No, it's not part of
Okay.
the options.
No problem. Let me just take 2 minutes to just then go through what I was going to speak on. So in terms of the ophthalmology pipeline within Roche, we have a couple of molecules that we are looking into within the ophthalmology space, as well as different indications for which these molecules will be working. So for example, we already know about the neovascular age-related macular degeneration. We already know about DME, which is diabetic macular edema. And today we've spoken about branch retinal vein occlusion, central vein retinal vein occlusion, but we also have indications for uveitic macular edema, diabetic retinopathy, of course, and geographic atrophy, and as well as getting into a bit of the space of thyroid eye disease. So this is some interesting things that are coming. We have some various clinical trials ranging from phase 1 to phase 3 in these particular indications. And in terms of the molecules that we do have, in terms of the mechanism of action, we have different antibodies. We've got the DutaFabs, which is the dual targeting fragment antigen binding molecules. We've got the POT delivery system. We've got the antisense oligonucleotide and stem cell therapy. So molecules that work within the particular space. So in the last slide that I'm looking at on my side, which unfortunately you can't see, we just wanted to speak about what exactly is our strategy in ophthalmology as Roche, and what exactly do we aim to do. And I'd mentioned as well in my introductory statement that we really just want to improve the patient's outcomes by looking at their individual needs. And how do we want to do this? It's through improved outcomes via the novel mechanisms of action, such as the dual blockade or the new targets that we have in our different molecules. We also have the long-acting delivery methods, such as the PDS, which is the port delivery system. And then we also wanted to speak a little bit about the partnerships, the partnering that we've done with external parties to actually bring to life our footprint in ophthalmology. For example, we've done quite a bit with Ionis and Insights and Lineage, as well as, of course, our internal innovation within Roche itself, within our research and early development organizations. So yes, I think that's basically what I wanted to speak on today in terms of our pipeline and our footprint in Roche. But I also want to say thank you very much to all the participants that came to attend this particular meeting, for your active engagement, your contributions, your questions. We appreciate all the insights that we've also collected from this meeting and all the learnings that we've also learned from this particular meeting. And I also want to thank the organizing committee for helping us to actually have this particular session come through. And of course, a very big thanks to the speakers, Dr. Onyango, Dr. Kareko. We appreciate your efforts in making this meeting a success. And with that, I want to hand it back to, I suppose it would be Dr. Mora.
Could I ask something, Angela?
Yes, yes, please, of course.
Thanks for that. Thanks for that. The Voyager, I think the port delivery system of ranibizumab being compared to, there are two things. It's a real world, it's a prospective study. That was opened up again?
No, not yet. So there's a halt on that particular piece for most of the countries outside of the US. And we're still looking into that, and then we'll be able to give you updates once we get some more information on that.
Thanks, we are ready.
Yeah, good to know. So back to you, Dr. Mora. Yeah.
Thank you, Doc. I'd like to thank everyone for attending today's CME. I believe we are on time to conclude this meeting. So thank you again for attending, and have a good evening.